Pre-hospital fluid therapy is a common practice among paramedics. However, there are a number of medical cases in which pre-hospital fluid therapy should be avoided or used with severe precaution. This presentation identifies the damage that pre-hospital fluid therapy can cause with a recommendation against it for cases such as hypothermia, heat stroke and exhaustion, hypoglycemic emergencies, shock, and trauma. In cases of hypothermia, the target of pre-hospital care is to re-warm the patient. Warming in pre-hospital setting is risky as the heart is irritable, especially between 28 to 32 degrees Celsius, and movement or manoeuvres can provoke an episode of ventricular fibrillation. There are many methods to actively warm the body temperature of a patient using external and internal re-warming techniques. Warm IV fluid therapy is a method used for internal re-warming, which can be difficult in a pre-hospital environment. This is due to limited available and accurate warming devices. Warming with a microwave can create uneven heating, and if the fluid is heated beyond 40 degrees Celsius, there is a risk of endovascular damage. Other methods to warm IV fluids, such as heat packs, are logically complicated as heating fluids to exact infusion temperatures can be difficult. In a pre-hospital study, comparison of re-warming methods showed warmed IV fluids were ineffective and actually dropped the patient's temperature compared to external warming techniques using hot packs. In instances of heat stroke, rapid cooling and volume replacement is indicated. Overzealous fluid therapy, especially in patients with cardiovascular disease, can result in pulmonary edema and further complicate patient presentation. Heat exhaustion is another condition where rapid cooling is indicated. When heat exhaustion is a result of salt depletion, hyponatremia and hypocholeremia can develop. Fluid therapy is indicated, but when administered inappropriately can cause negative patient outcomes. In the correction of hyponatremia, too rapid of sodium correction via fluid therapy can result in cerebral edema and permanent neurological damage or death. Rate of fluid correction should be proportional to the rate of onset, otherwise fluid therapy can prove to be lethal. If a patient presents with symptoms of hypoglycemia, a history of diabetes, and altered levels of consciousness, there may be a high possibility that they are suffering from either hyperosmotic hypoglycemic non-ketotic syndrome, or HHNS, or diabetic ketoacidosis, or DKA. In this case, the two present very similarly, however require differing treatments. If the condition is not treated correctly, it can cause adverse reactions of coma, shock, and death. The Joint British Diabetes Guidelines state that DKA requires an initial treatment of insulin as it is an acute condition that does not affect osmolality. This is then followed by a fluid infusion. However, HHNS conditions require rapid fluid infusion followed by an insulin infusion after blood sugar level testing. If the patient presents with DKA and the attending officer administers fluid therapy, the treatment will be ineffective in reducing their hypoglycemia due to their lack of insulin production, thus worsening the patient's condition. Therefore, in the case of pre-hospital hypoglycemic emergencies, fluid therapy should not be used due to the inability to diagnose which condition requires treatment, and a movement to hospital as earliest as possible would be the appropriate course of action. There are a number of studies that indicate that the current practice of fluid therapy for patients with renal conditions is actually more harmful than beneficial. Volume depletion occurs with acute kidney injury, and the standard approach is for repletion of that volume through fluid therapy. However, it is evident that fluid therapy can be harmful in acute kidney injury, causing edema and an excessive cohort of progressive dysfunctions with the increased abdominal pressure, including decreased cell perfusion and organ failure. Therefore, the use of pre-hospital fluid therapies for presenting patients that have acute kidney injury should be avoided to minimise any further damage. Shock is defined as the inability of the body to maintain adequate blood flow to peripheral tissues, resulting in generalised cell hypoxia. The types of shock are classified into hypovolemic, cardiogenic and obstructive, and distributive shock. For the purpose of this presentation, we will just look at hypovolemic and cardiogenic shock. Fluid therapy or resuscitation is used in shock to restore adequate oxygenation to the peripheral tissues. The most common condition that requires volume replacement is hypovolemic shock as a result of blood loss from hemorrhage or dehydration. However, within the three types of shock, there are conditions in which fluid therapy should not be used, as it can potentiate a worsened outcome for the patient through the distribution of naturally occurring mechanisms or by instigating secondary adverse outcomes. Cardiogenic shock is recognised as the heart being compromised as an effective pump to the point where cardiac output is significantly reduced, affecting contractility, workforce, or cardiac rhythm. Published literature and guidelines differ in relation to fluid therapy in cardiogenic shock. The Queensland Ambulance Service advises precaution in the use of sodium chloride 0.9% fluid therapy in patients with acute heart failure or a history of heart failure. Rapid administration in patients without significant loss of fluid or with underlying cardiac problems may result in pulmonary edema or congestive heart failure. Whereas Gregory and Ward state that fluid therapy in the treatment of cardiogenic shock is not supported with the present guidelines, and paramedics should not administer fluids to these patients in the pre-hospital phase of care. One form of hypovolemic shock that is an associated contraindication for pre-hospital fluid administration is burns. Guidelines that are in place presently do not advocate fluid therapy to patients with burns less than 25% total body surface area or a time to hospital of less than 30 minutes. Fluids should not be administered in the event of significant facial, neck or upper chest burns due to the adverse effects of fluid therapy, which increases the risk of interstitial edema and tissue swelling. These adverse effects can lead to a higher potential for the airway or ventilation to be compromised. The use of fluids in patients with hypovolemic shock resulting from blood loss in penetrating thoracic injuries should be delayed until operative intervention is available. In this study, it was found that delaying fluid therapy in comparison to immediate fluid administration showed a statistically significant improvement in patient mortality. Fluid therapy is a controversial topic that is debated constantly in the academic community. However, there is consensus that despite what type of shock a patient may present with, if the time to hospital is less than 30 minutes, fluid therapy should not be implemented, as it increases time at scene and can be shown to increase morbidity and mortality. For decades, aggressive administration of intravenous fluid therapy has been considered as the paramount management approach for trauma patients in the pre-hospital setting. It was thought that by replacing lost intravascular volume, tissue perfusion and vital organ function could be maintained. Therefore, intravenous fluid therapy would allow patients to arrive at hospital in a stable hemodynamic state. However, current literature no longer supports the use of intravenous fluids in trauma patients, as it has been shown to aggravate blood clotting factors, delay departure to definitive care, and increase mortality. Aggressive administration of intravenous fluid therapy before uncontrolled hemorrhage is surgically controlled will increase bleeding and mortality. fluid infusions promote further hemorrhage by increasing blood pressure and dilating coagulation factors. As a result, clots become dislodged, blood viscosity is decreased, and the blood's oxygen carrying capacity is reduced. These consequences of fluid therapy inhibit the body's hemostatic mechanisms, preventing it from regaining the ability to cease hemorrhage. Thus, further uncontrolled hemorrhage is exacerbated, causing hypovolemic shock and potentially death. Additionally, in the case of hypovolemic patients, intravenous access proves to be more difficult due to vasoconstriction and hypotension. This results in increased failed attempts and further on-scene delays. The time to initiate intravenous infusion should never exceed the transit time to hospital, indicating that IV fluid administration is no justification for delaying the transport of unstable trauma patients with uncontrolled hemorrhage. Current research also shows little evidence supporting the administration of pre-hospital intravenous fluids in patients with penetrating trauma. In cases of penetrating chest and abdominal injuries, an actual decrease in survival has been associated with pre-hospital fluid therapy. Similarly, with patients experiencing uncontrolled hemorrhage, a delay of aggressive fluid resuscitation until operative intervention improves the outcome in patients with penetrating injuries. It is advocated that fluid therapy is withheld if the patient has a palpable carotid pulse and until active bleeding is addressed. In a study performed by Bickel, patients receiving immediate fluid therapy were associated with a significant increase in systolic blood pressure and intraoperative blood loss. Furthermore, the initial hemoglobin concentration and platelet count were significantly lower than the patients with delayed fluid therapy. Ultimately, patients with delayed fluid therapy had a higher rate of survival than those who received immediate fluid therapy. This study demonstrates the damage associated with pre-hospital intravenous fluid therapy in patients with penetrating trauma and cements that there is little research to support any survival advantages associated with IV fluid therapy. Aggressive pre-hospital intravenous fluid therapy can also result in secondary abdominal compartment syndrome, or ACS. Secondary ACS occurs when increased intra-abdominal pressure causing end organ failure develops in a patient without primary abdominal injury. This condition is most often associated with patients receiving excessive intravenous fluid therapy after trauma, burns, or septic shock. Current literature suggests that the development of secondary ACS is common due to the aggressive pre-hospital fluid resuscitation, especially within the first 24 hours after injury. Prevention of secondary ACS should focus on eliminating aggressive pre-hospital intravenous fluid therapy until the patient is transported to definitive care. In cases of traumatic brain injury, the primary insult is not indicative of the long-term neurological deficit. Instead, the processes originating from the initial trauma lead to the detrimental onset of secondary brain injuries. Primary injuries can cause damaging effects to neuronal tissue and lead to inflammation, edema, and ischemic injuries. The goal of pre-hospital care is to limit the above by managing hypoxic and hypertensive episodes and reducing intracranial pressure. Protocol for suspected or known traumatic brain injury indicate intravenous fluid therapy for hypotensive patients only on an as-need basis. Guidelines are to give fluids to a not to normal systolic blood pressure or permissive hypertension using a titrated dose technique to reach systolic blood pressure of between 90 to 100 milligrams of mercury. In cases of traumatic brain injury, aggressive fluid resuscitation may have unfavorable and negative effects such as blood clot displacement, hypothermia, and diluting effects on coagulation factors that can accelerate blood loss. Overall, it is evident that the use of pre-hospital fluid therapy in the cases of hypothermia, heat stroke and exhaustion, hypoglycemic emergencies, shock and trauma can have adverse effects on the condition and overall morbidity and mortality of patients.